Okay, let's see. All right, so you should see a radiograph. And this is a 63-year-old man who was presenting with cough and recurrent bouts of pneumonia. So this is his chest radiograph at the time, and you can see he's got sort of bilateral, what looks like nodules and some consolidation in the right upper lobe there. We see on the lateral as well. Normal volumes, no effusion. So it looks good for an infection, and you'd wonder about fungal infection with what looks like nodules, maybe blastomycosis or something. But with his history of recurrent infections, of course, we'd have to think about something structural or immunologic. So he ended up on a CT scan because of the recurrent infections, and we can see there's a lot of nodules that are associated with airways. So we've got the so-called tree and bud. So there's a bronchiolytic component. And let's see who just joined in. Yeah, so bronchiolitis. We've got a little bit of bronchial wall thickening, but not a lot, and then some consolidation around it. So it looks really good for an acute infection, although there's quite a bit of disease. You might wonder about something more chronic, like nontuberculous mycobacterial infection. Not the most typical demographic, but does occur. Tree and bud, interestingly, is not that common with endemic fungal infection in my experience. I've seen it with aspergillosis, but we don't see it with histo or blasto, or I'm not seeing it with cocci. So he ended up getting a bronchoscopy and everything, and they had a lot of secretions and stuff, and they sent everything off, and it's kind of a mixed flora. But what was interesting is because of his history, they did other testing, and there was no immunodeficiency, but he turns out to have cystic fibrosis, presenting in his 60s. And this is, I can show you, he's got a nice, healthy looking, well, we see of it, a nice, healthy looking pancreas. So adult onset CF is well known now. I'm not sure what these patients were called years ago. We've got much better genetic testing, and this is not the common Delta 508 mutation we think in children. I forget exactly which one it was. I'm not up to date on all the different CF mutations. But he's presenting predominantly as a bronchiolitis. And so he's confirmed cystic fibrosis by that, but they tend not to have the exocrine problems that we see in people who present in early childhood. And most of the adult onset I've seen has been people in their 30s and maybe 40s, but I think he's the oldest one I've ever seen. Curious what your experience is, David.
Well, we have a big cystic fibrosis adult clinic, and you know, this looks like the ordinary sort of pseudomonas or staphylococcal colonization that these people get. It looks as if he probably has he's got some rarefaction posteriorly on the right there that makes me think that he probably has some air trapping. So there's some, you know, small airways dysfunction, not just clogging with secretion, but he probably has some air trapping. Some of that could be reversible if the infection and the swelling go down. But it looks like sure looks like the ordinary bacterial colonizations, usually Pseudomonas, or those are the common bugs. So onset in 60s, that's pretty remarkable. We have a few cases like that. It's usually an unusual mutation, as you pointed out. The interesting thing about cystic fibrosis is the findings in the lung are not cysts and they're not fibrosis.
Right.
Those findings were actually the description of the pancreatic disease in children that died early and that had their pancreases evaluated at autopsy. So cystic fibrosis really refers to what you would expect in the pancreas, early in the course of disease. So it's a little misleading because radiology residents start looking for the cysts and the fibrosis, and they're not going to find it in the lungs.
That's right. The closest thing you'll find is cystic bronchiectasis, but you're right. I've seen one good case of pancreatic cystosis, but that was it.
Right.
Okay, well, so all three of my cases are related, so it's interesting, and I came across them all this week. So this is a 27-year-old male. He has a history of chronic sinus disease, nasal polyposis, asthma, and an aspirin allergy, which is associated with nasal polyposis. And this is his chest CT. And you can see the same kind of thing, albeit a lot less exuberant, little tree and bud. Um, it's a little bit of bronchial wall thickening. These are thicker cuts, but I think you can still appreciate that. And as we go down, there's some mucus plugging, more small airways nodules, these interesting bands of atelectasis, but clearly another airway disease. Little heterogeneity of the lungs. I suspect there's also some air trapping in there. You can see some smaller tree and bud. So the question with him is, and he's had some in previous cultures of his sinuses, questionable hyphae or something, and with his asthma diagnosis, is this going to be an atypical ABPA? Is this going to be a cystic fibrosis? He's a young black man, so it's less likely, but it does occur in that population. And this would be sort of, again, a little bit later onset, but I'm not familiar with it being associated with sort of sinus disease and nasal polyposis. To me, that's more a chronic allergy problem. I did look around a little bit and saw he had a history of some eosinophilia at times, maybe some elevated IgE. So I suspect this is a variant of ABPA. Where it's more a bronchiolitis than a bronchitis. He doesn't have the typical bronchiectasis, but that doesn't rule it out. And it would fit with his asthma and sort of atopic eosinophilic type picture.
Yeah, I agree. And he's got very nice bronchial wall thickening there. So he's got central and, the peripheral tree and bud, small airways disease. So large and small airways disease.
Mm-hmm.
Nice thickening. And I think aspergillosis is always there. And I think in this population, it takes hold to varying degrees. You don't have to have the florid, central bronchiectasis, large mucus plugs. You can have smaller airways involvement. We have seen cases of ABPA that people thought were going to be atypical mycobacterial infection because they were so widespread, tree and bud abnormalities, and it turned out all to be aspergillus. So I think I agree with you. I think this is on the spectrum of bronchial involvement with an allergic component, attributable to aspergillus in the setting of asthma. Yeah,
that's kind of what I'm thinking too. All right, and then this last case, this is one I just recently saw. This is a 19-year-old woman with no past medical history other than an asthma diagnosis. I put that in quotes because I couldn't find like real pulmonary function tests with bronchodilator challenge or methacholine challenge or anything like that. Who's often on an inhaler, but no exposures, doesn't smoke or vape or do anything other drugs. Part of her problem is her care was pretty fragmented, it was all outside. So trying to figure out the history. So I talked to a pulmonologist who saw her, and they really found no additional history. But she was referred to us for bronchiolitis as well. So here's another case of airways disease, and you can see there's lots of tree and bud. Her larger airways aren't quite as sick as the last guys. There may be a few areas of thickening. I think there's some minimal bronchiectasis in a few areas like that. Bronchus is too thick there, but it's much more extensive small airway nodules there. And then she's got a few sort of ground glass nodules around some of this, so just probably more extensive inflammation, tree and leaf or something, if you want to call it that. And then pretty extensive down here in the lower lobes. She's normal stature. She hasn't lost weight. And she's, as far as I can tell, she hasn't had a long-standing history of infections. I think she had one respiratory infection a while ago, some, uncomplicated cystitis, but nothing like recurrent pneumonias or recurrent hospitalizations for that. Just some orthopedic stuff for like hands or something. So, and no medications other than she has an albuterol inhaler for her so-called asthma. So I think with her, I think this may end up being another cystic fibrosis, sort of later onset. She's 19. It would be one possibility, maybe an immune deficiency, but I would have expected more infections. All she has is a cough, so no fever. She hasn't had a leukocytosis. And then, I mean, this would be a great look on imaging for diffuse panbronchiolitis, but she's completely the wrong demographic. I know it does occur outside of Japanese males, but it's already a pretty rare disease, and to occur in a 19-year-old white female would just be even more rare. So rare times rare is exceedingly rare.
Unless she's traveled to Asia, because there are Caucasians that get it.
Right. But I don't think she's left the Midwest from what I could gather.
Okay.
So really no exposures to anything, no occupational or domestic exposures. But yeah, I did raise the question of mycobacterial disease as well, like NTM. I mean, she's kind of young, but there are cases in younger people, and they may just have a cough. Although with this burden of disease, you'd expect more. But young people are pretty tough. So yeah, there's sputum cooking, there's CF mutations cooking. I think immunoglobulins are cooking. But there's no family history of any lung disease that I could glean out of the patchwork of notes from all the various places she'd been seen over the years.
And her pancreas.
But
Okay, do we have pancreatic views?
we have, yes, and we have a nice juicy pancreas.
Okay.
Yeah. So
Okay.
3 cases of airways disease. One has a confirmed diagnosis, one has a highly suspected diagnosis, and this is the unknown one. But typically, I think my point when showing these is typically I always teach my residents, when you see tree and bud or these little bronchiolitis with the defined branching nodules, 9 times out of 10, if not more, it's an infection, and the other remaining is typically aspiration, with less than 1% probably being all the other rare things that cause tree and bud. But the context of the patient is so important. Is it acute? Is it have they had ongoing problems, recurrent bouts of things? Because most infectious bronchiolitides run their course. Things like RSV and mycoplasma sometimes does this, all less commonly, but they typically occur for a few days, and they either self-limited if it's viral, even some of the bacterial ones, or they get some antibiotics somewhere and it takes care of it. So you have to kind of know if these symptoms have been persisting, and then you have to start thinking of chronic things such as CF, ABPA in the right patient. Immunodeficiency would be another one, but typically patients have some history of recurrent infections with those, but it can be mild and it can be developing over time. So worth exploring. And then there are a few other rare things, but 3.
Including, we saw a case of thymoma that had autoimmune bronchiolitis, and
yeah,
colitis and rheumatoid arthritis too, and stuff like that. So
yeah, like a follicular bronchiolitis for sure.
And ciliary dysmotility ought to be on the list, because with the that can give you bronchiolitis too, because you're just not moving the secretions. Things get infected because this is sluggish pooling. But usually there's more airways disease, and it's more basal predominant.
Right, and they often get sinus disease too.
Right.
Which she does not have, interestingly, but we shall see.
Cool.
So I maybe by next week I'll have some more answers, but I thought these 3 cases nicely complemented each other.
Indeed.
All right, David, are you ready?
I'm ready.
All right, I'm going to make you the presenter.
So this case is a kind of a cool teaching case, I think. This is a woman who's recovering from abdominal surgery. I think this was a liver transplant. She did have a pneumothorax, and you can see this nice pleural line out here. At this point, she has a thoracostomy drain in place. And then the drain was removed, and we have another radiograph. And now we've got this very bold edge here, and we still have our thin white pleural line here. So these are skin folds. We've got a skin fold here and a skin fold here. I thought this was a good teaching example, because you can compare the findings of skin fold, which can mimic pneumothorax, with actual pneumothorax. So first off, an actual pneumothorax is a thin white pleural line between black underlying lung and black pneumothorax outside. So it's black, white, and black, whereas a skin fold is just whiteness, usually increasing whiteness going up to sudden blackness. So we don't have a thin white line here, we just have an interface, white meeting black. It's often increasing whiteness on the way to black. Not only that, but there's a mock band associated with a skin fold that is not associated with pneumothorax. So outside the white part here, there's actual extra blackness of about 1 millimeter of extra blackness hugging the white edge. So the presence of a mock band, which is an artifact, it's not real, is another indication of skin fold versus pneumothorax. So it's really handy, I think, to have them side by side here, on the same side in the same patient at the same time. And here's another another skin fold, and there's probably a little bit of air trapped in a crease there between folds of skin. So why does skin fold follow the thoracic wall the way a pneumothorax does, and makes it even more confounding? And that's because the skin fold is created by the pressure of the chest wall on the skin, and then the cassette underneath the skin. So the skin is being pressed by the chest wall onto the plate. This is where room air comes into the edge of the skin fold where the skin is puckered there. So it's going to have this shape of the chest wall because the chest wall is what is pressing the skin against the plate and forming the piece. So teaching example, both findings the same lobe, just inches apart. You can help, I think it helps crystallize the differences between skin fold and pneumothorax.
So,
okay,
great case. So what you're saying is if we can have malleable detectors like some of these new foldable phones,
yeah, right.
eliminate the skin fold artifacts if they conform to the patient's body.
That's right. Yeah. Okay, and that will be an important technical advance. So we ought to really concentrate on doing that. I think it's going to be too fragile.
Retire early.
Okay. Okay. Let's see what I've got next here. So a mediastinal mass, I think in a 29-year-old here, this very well-defined mass, and this was April. Already this month in May, this thing is much larger. It's probably twice the volume already. So this is a rapidly growing mass here. Just in case you think it's an artifact, I think this helps confirm that it's an anterior mediastinal mass. And let's look at it on CT. It is fairly homogeneous. It's got a little bit of variation in density here. This is a contrast study. I don't have any non-contrast studies, so I don't know whether this is enhancement or just that there's some native difference in tissue densities within this mass. It is having an effect. It's compressing the main pulmonary artery and so forth. And I think currently there's now with a larger mass currently, there is now a pleural effusion. The other finding is that there is a pericardial effusion now. So this mass may be involving the pericardium and may have invaded pericardium. And on the current CT now, a month later, the pericardial effusion is larger, and he does have now some chest pain. So the chest pain could be coming from the pericardial component. So this mass turns out to be a Ewing sarcoma. So usually it's a disease of even younger people, but I've seen a number of these Ewing sarcomas or peanuts in patients into their 20s. So it's not out of range. So pretty impressive mediastinal mass. I don't think that would have been on my differential, but
no, I thought it was going to be a germ cell tumor given its rapid growth or some, but I think another good pearl is anytime you see a big mass in the chest, always include sarcoma.
Right. Especially when it's growing rapidly too.
So,
okay.
Did they resect this, or are they going to do neoadjuvant therapy?
I think he has a chemotherapy catheter in. So, and he was just admitted this week. Okay. This is outside imaging. We're pretty early in the process, and I haven't even checked the pathology. I'm just relying on the requisition at this point to know whether the pathology was reviewed here and there's any refinement to that outside diagnosis of Ewing sarcoma. Okay. And then this is a lung transplant patient. You can see the transverse sternotomy apparatus here. And this is, I think, a couple of months out. And previously, this part of the left apex was clear above the aortic arch. And now we have this irregular blob up here. We do have pleural effusion and some consolidation in the left face. So this person was CT'd, and I think this is going to be too MIPSy. Let's see if I can get a better, that's MINIPS. Let's see, here we go. Standard inspiration. So here is that mass above the left hilum above the aortic arch there. So it's an irregular blob. It's fairly compact. You'd think first of infection here. So the infections we see are often aspergillus, and aspergillus in this setting is much less aggressive than it is in the stem cell transplant population. So it tends to be a more indolent nodule. So this would be just fine for aspergillus. We also see cryptococcus in this transplant, solid organ transplant population. So crypto would be on the list. Nocardia would be on the list, and PTLD, because sometimes these nodules are not really infections, but they're PTLD from Epstein-Barr virus. And then it's hard to know what's going on in this left base here, how much consolidation this is and how much atelectasis it is from pleural effusion. At this point, there's a good sized pleural effusion, so it's hard to know if there's also infection down here. So this was evaluated, and this turns out to be nocardia. So haven't seen very much nocardia in the transplant population, cellular organ transplant population recently, but 15 years ago we did a study, and nocardia was a very common cause of nodules in people who'd had kidney, heart, liver, and lung transplants. So cellular organ transplants, nocardia is definitely on the list. Here's a case of nocardia. It's got a little air bronchogram in it. That's supposed to make you think about lymphoma, so that would keep the PTLD consideration live. I was very confident that I was making the correct diagnosis among these candidates. The aspergillus versus nocardia versus cryptococcus versus PTLD. And it turns out it was completely random. At least my calls were completely random. I could not distinguish these different kinds of nodules in the cellular organ transplant population. So despite the humility, we published that paper anyway. You just have to suck it up. Okay, so this was nocardia. And then here's a woman with chronic abnormalities. So she's had pleural effusions. I have seen these pleural effusions over 9 years in this woman. They're currently a little bit larger than they were, 9 years ago, but larger left than right pleural effusion, and then some irregular lung blobs. And let me show you what our current CT looks like in this person, who is from Honduras, I think. So there's all this mediastinal and hilar mass going on here. I don't have a non-contrast CT to show you, but there is some calcification. These are not just vessels that we're seeing in this. And I think, again, there's calcification here. I would like to look at a non-contrast just to make sure that, given how bright this is, I don't think that this is contrast, but this person would be entitled to have some collateral pathways opening up. And we got this irregular pulmonary artery here. So, and then we have the chronic pleural effusion. There's some pleural thickening. We have some lung calcifications. And this turns out to be granulomatous fibrosing mediastinitis. So she has GFM. It's presumed to be due to histo. Jeff, I was going to check your fungus article to see whether you talked about what is in Central America, because her being from Honduras, I know that there's cocci, I think, in Central America. I didn't check to see whether histo.
I'm pretty sure histo is there because it's in Panama where it was first described.
Is that right?
Yeah, when they were digging the canal. What are those crazy vessels in her left lower lobe there? It's huge.
Yes, I think because of her, she's got this venous obstruction going on. I didn't talk about the pulmonary veins, but pulmonary veins, or her inferior pulmonary vein, I think is obstructed. So I think she's got varices.
Yeah.
Here. And I think it's the pulmonary venous hypertension that is causing this pleural effusion. So this plays into a very nice physiology here. If you have high pressure in veins, that's when you get pleural effusions. Normally with heart failure, pleural effusions are larger on the right than the left. Hers are larger on the left than the right, and it reflects the differential disease that she has obstructing her pulmonary veins with this this varicoid, these varices that have developed there. So, and I think that also contributes to her right pulmonary vein being pretty large here, because there's a lot more blood flow occurring on the right than the left because of this obstruction over here. So granulomatous fibrosing mediastinitis, this is really a Midwestern disease. In her case, it's a Central American disease, and attributable to histo, although I don't think we've pinned it down with any bacteriology or anything like that, or serologies in her case. And then this varicoid, alteration in her inferior pulmonary vein on the left. So GFM strikes again. Somebody showed a case last week or the week before. And then this one just came up fresh this week, but I'd seen it more than 10 years ago, and I've now added the new imaging to it. I think with the venous problem, she also has some pulmonary hypertension.
Mm-hmm. Yeah, we usually we never really find the cause most of the time. I mean, because it's antigen mediated, and who knows. But typically, what we see with the histo, not always, but is a big partially calcified mass. It's usually on one side, and it just sort of takes out everything in its path. I think I showed one, or maybe not. I don't know. There are cases of more of an infiltrative type. We've seen it with sarcoid, other things, but I think some of them are probably attributed to histo as well. For some reason, some people just don't calcify it as much. But I mean, typically the veins go first, then the arteries, then the airways.
Definitely, the most common vessel that's affected is the superior vena cava. Mm-hmm. So that's the most common, and then any soft structure, pulmonary veins, airways, and arteries can also be involved. I've seen a number of cases though, Jeff, that just had modest calcifications like this and mm-hmm. didn't have a big particular blob. And there's obviously a lot of scar tissue here. One of the first cases I saw, years ago at Duke in the 80s, looked like a hilar mass, and they biopsied it and they thought it was a sarcoma, because with this fibrotic process, there was so much atypia. These cells were going crazy. So it's very easy to mistake it for sarcoma because there's so much cellular atypia. It's such an aggressive fibrosis that it's, it gets a little messy.
Yeah.
Kind of got a breast problem here
just
too.
Not that.
Right.
Interesting.
Okay, so GFM, not the first thing you'd think of, but I'm glad that you point out it can be seen in people from Central America. So I'll put that on the list.
Yeah, I remember when I was reading about histo, it was initially thought to be a fatal fungal infection because there were a couple of autopsies from workers at the Panama Canal who died from it. And it wasn't until I think the 1940s, probably like right after World War II, where they had skin testing for histo and realized like over half the U.S. population is positive for histo. So right. It turns out that they just died with histoplasmosis rather than from it. But bats are carriers of it, and of course, there's a lot of migratory birds that go from the Midwestern United States down to Central America in the wintertime. A lot of our songbirds do, and of course, they're vectors of histoplasmosis as well, in addition to just chickens and other things. But it's just everywhere around here that we don't even think much about it. I mean, I almost every CT I read has at least one calcified nodule, and several have calcified lymph nodes or splenic calcifications.
Well, and it's not considered to be endemic in North Carolina, but North Carolina has a big big poultry industry, and so we have seen it in farmers in North Carolina, or chicken farmers, mm-hmm. because of exposure to birds. There was a case in Seattle that was related to somebody who was working in renovating an old building, I think the train station downtown, and there were pigeon droppings, and so this person acquired histoplasmosis, and it was thought to be from the birds that were living in the rafters. They're the pigeons. Mm-hmm. So it's all over the place, and it loves bird feces.
Yeah, and then you've got there's caves down in I think like Costa Rica and some other parts of Central America and Mexico that have bats that carry it as well.
Right. Yeah.
I think it's their higher body temperature. The fungus can just kind of hang out, and then when it enters the the atmospheric temperature, it becomes more of a whatever is a spore type thing. Because it's interesting because there's not person to person spread of histoplasmosis because the yeast form is not contagious.
Got it.
All
One
right.
of our who was on corticosteroids for sarcoidosis visited some national park that has caves. I think it's in West. I don't remember the name of it. And he got acute histoplasmosis from from the bats in that cave in a national park or a state park. So you don't have to be a serious spelunker. You can just be a tourist.
Yeah.
In that environment.
Where you're N95 when you go in the caves.
Yeah. Okay,
all right.
those are the cases.
Well, a little short today, but those were great cases, David, and good discussions. And hopefully Peter will be back next week, and we'll hear from Travis soon. And I think Howard's going to be gone another week or two. Let's see, there's something in the chat. Oh yeah, Vasilios has his venous infarct. He said he'd show. That'd be great. I'll make you the presenter. More cases are always good.
Okay, so can you hear me?
Yes, we can hear you and see your screen.
Okay. And your screen, great. So this was a case that I shared already with Professor Caney. I think it's very interesting, and it is actually a testament of the importance of thoracic imaging. So this is a man in his 50s, and about a week ago, he was subjected to a VATS resection of a nodule in his left lower lobe that proved to be an amartoma. And about 3 days after the operation, we were called for a consultation because he was feverish and he felt fatigue, and he also reported a strange feeling in his left hemithorax, like it was bulging. And so this was his CT. There was this loculated pleural effusion. And I think that the interesting finding is that going south, there is some granulous opacities, and we have this like a bird's nest appearance somewhat. And I think it's not that, maybe it's not the best example of a bird's nest sign, but I think that it's pretty characteristic enough to raise suspicion for infarction. Unfortunately, the CT was already ordered by the internists, and so it was a non-con CT. But even in this, and I think it's high resolution, so it's a bit sharp, the imaging. But I think that even in the mediastinal window, we see an appearance that fits with the bird's nest sign. Let me see if we have a more soft window. Yep. So this is the appearance, and also we see that there are clips in the area of the left inferior pulmonary vein. So this raises the possibility of a venous infarction, and then a CT with IV contrast was ordered. So I think that also in the lung window we see an appearance that I think it's compatible with a bird's nest sign. And I'm scrolling up and now. And in the mediastinal window, so we see that, as expected, the left upper superior vein is okay and is going to the left atrium, but we see that the left inferior pulmonary vein is gone. And also there's this staple in the area. So it's a rare complication, but unfortunately it can happen. Okay. So we see again that the vein is off, and this caused the infarction. And if it's okay, I have some gross pathology to share with you. Can you see this image?
Yes.
Okay, so it's pretty much typical of a venous infarction. So the left lower lobe, as you can see, is very congested. It's like bluish, and it's pretty much typical of a venous infarction.
Yeah, and I think your point about the bird's nest appearance is a good one. Those venous infarcts have they look like giant infarcts you see with pulmonary emboli. David, do you think what we're seeing with some of the mucor is infarction as well? Yeah, sometimes we see it with mucor, and I suspect because of the angioinvasion with mucor and aspergillosis.
From what I know, it's very interesting, and I think that the bird's nest sign it has a common pathogenesis that is directly related to blood vessel obstruction, because from what I remember, the Nocardia species is far more angioinvasive comparing to Aspergillus. So the bird's nest sign is indicative in the right clinical setting in immunocompromised patients of fungal disease, but mainly of mucor. And I think that this is due to the fact that mucor is far more angioinvasive comparing to other fungus species.
So what I agree with you, and I think your case today makes me wonder whether what I've assumed was that angio invasion was arterial invasion. I just wonder how often it's really venous invasion in the setting of mucor, because of this systematic bird's nest that you're showing today from venous infarction. So maybe I've just been wrongly assuming that we were all the time we were talking about angio invasion, we were talking about arterial invasion. Maybe it's really venous, or at least venous a lot of the time.
That's what I wonder too. And it seems like it'd be easier to invade a vein too, right? You have less muscle, lower pressure. Plus, there's a lot of oxygen in the pulmonary veins.
Also, Professor Koenig, from what you said, the venous infarction, in contrast to an arterial infarction, in the case of a venous infarction, the lung is going to be expanded and congested.
Right.
So in arterial infarction, and this is a question, you don't expect the lung to be that edematous and expanded.
Right, because typically with these complicated, like either with a torsion or just a venous infarct, and I've seen a couple of these too. And I think what happens is they sometimes have variant venous anatomy, or it's just their anatomy is a little different. So when the surgeon's in there with a scope, they typically try to identify the right one. But you can imagine in a small space with unusual branching, it's going to happen sometimes where you staple the wrong one, or your staple line goes too far, which is probably what happened in this case. But you're right, and it doesn't happen right away. You see it over a few days on the postoperative imaging, that remaining lobe or lung becomes denser and often expands outward. And that's what you see sometimes with torsion. You'll see the fissure move, but you don't see it immediately postoperative. You see it typically, I don't know, a couple days later as it starts getting more and more plugged up and expands out. And then probably what happens is the pressure is so great that the veins, that the inflow and the outflow prevents any inflow, and then you get that venous infarction like that. And that's why on the path image you showed it, or the gross specimen, it's so red and just engorged looking. That's a really nice example, and it's nice suspecting it on the non-contrast because it's probably not what the surgeon was thinking. So looking at the radiographs can help you maybe decide that you need to give contrast right away, because I suspect on a radiograph this looked more, they were probably thinking empyema or something, given the
Exactly. This was their initial thought, and actually they were surprised that we didn't ask for a thoracic surgeon to insert a tube. And yeah, we said just because the imaging actually helped us, because clinical examination is extremely helpful, but it has its limits. And the best sign in this case was of extreme clinical value.
Was the pleural effusion, was it a hemothorax or was it just a serous effusion? What was it like?
It was a serous effusion, exactly. You're right.
So, you know, this may be another case where you have venous hypertension and you get pleural effusion.
Yeah. Yeah, so actually it's a companion case. Yeah, I'm glad about it.
Well, thank you for sharing that one. That was excellent.
Okay, of course. And I don't know if we have time. I have also another case.
We do have time. Yes, we do.
Okay, great. So it's not a COVID case. So just let me see. Yeah. So it's a pretty typical, and if you agree, because you are the experts, and at least in my experience, not a very specific sign. So so this is a lady. I'm going to withhold some history at the moment, and so you see that it has this areas of consolidation. I think that they form kind of a perilobular pattern at the basis. There is some, let me mark it up a bit. So I think that there is some bronchial dilation, and there's a reason that I am calling it bronchial dilation and not bronchiectasis. So we have this consolidative bands with a perilobular pattern, and going up, we see again that there is this bronchial dilation. And let me show you also the rest of the CT. Okay, some mild granulas. And actually, during history, the patient was on nitrofurantoin for about 1 year. And so after exclusion of alternative causes, the working diagnosis was chronic nitrofurantoin lung toxicity. So the interesting thing is that the patient was in very good clinical shape. So we decided just to follow up on the patient, of course, with discontinuation of the offending agent. And this is the CT afterwards. I think, because I have anonymized the case, I think it's about 4 months after, 4 to 6 months after, if I remember correctly. And so you see this dramatic improvement. Sorry. In this case. So, and then no steroids were given or any other immunomodulation. And the findings are almost gone. There's almost a complete resolution. And I would also like to highlight with this case that because there is a lot of hype about the post-COVID fibrosis, because actually I think that it's mainly organized pneumonia. We must be really careful about calling it fibrosis. Because as in this case, the improvement can be pretty dramatic. And actually, those that were described as bronchiectasis, and to tell you the truth, if I didn't have the last CT, I would call them bronchiectasis. Actually, they were bronchial dilation because they were reversible. So what do you think?
What was the drug she was on again? It went by too
Yeah,
fast.
it was nitrofurantoin. It was, I think, the brand name in Greece is Furolin. Furolin. I don't know if this is the same in the US.
I'm not sure if you're answering. Yeah.
Yeah, I think, was it macrobid here?
Yeah, but it's also called nitrofurantoin. So that's a famous cause of interstitial lung disease. So this is really a dramatic example of that drug reaction.
Yeah. And
But
so,
it's lucky to have so much reversibility here. That's not.
yeah, exactly. And I think that at least for me in this case, the striking thing is the dramatic improvement without any pharmaceutical agent.
Yeah.
So I guess all this perilobial pattern, actually, the underlying pathology was organized pneumonia.
Yeah. Wow.
I don't know what you think.
Agreed.
Yeah, the perilobular thickening is really nice. Now, I have seen cases where you sort of have mixed patterns of organizing pneumonia and nonspecific interstitial pneumonia. And with treatment, a lot of times the OP goes away, the denser stuff. But even her follow-up scan's a little abnormal. It's hard to know how much of that's permanent.
Yeah. There is some stuff left, I think, in the extreme basis.
Right, but your point about calling it bronchial dilation, I think, is very important, and that's something I've changed in my practice over the last several years, as I've come to recognize it more and more. I'm a lot more cautious about using the term traction bronchiectasis unless there's unequivocal fibrosis, because it does imply it's not reversible. And in your case, nicely illustrates the point that not all dilated airways are irreversibly dilated.
Yeah. Okay, so these are my cases. Thank you very much.
Thank you. All right, everybody. Well, have a great rest of your week, and we'll meet again next week.
Thank you.
All right,
Okay,
bye.
Thank you. Bye-bye.